So, from my standpoint, you know, we're here in Minneapolis because Minnesota is so far ahead on a state level in what this community care medicine is. I'll disagree somewhat with what Brett started out saying, that we met to talk about a curriculum, because we didn't really meet to talk about a curriculum. We all came to the table with what curriculums we had, with Gary's and Ann's curriculum and stuff that they had, and to look at what everybody was doing, see what common threads existed, and try to come up with a taxonomy, because Goodlow over here is having a heart attack about nobody's talking the same language, and he only speaks Oklahoman. He's from Texas. The only good thing that comes out of Oklahoma is
Can you slow down, sir?
Yeah. The only good thing out of Oklahoma is I-35 South. That'll bring you right to Texas. But you guys are
Patty,
unique.
you have me talking next.
Yeah. You guys are unique up here because you are integrated as part of your hospital systems. Your EMS systems are run out of hospitals, which is not norm if you look at the vast majority of EMS systems across the country. We are unique in Fort Worth that we are a sole provider. We have multiple systems, hospital systems, but we're the sole provider, so we're really Switzerland. And so when we started our program, we started to deal with our frequent, our loyal customers. We can't say frequent flyers. American Airlines doesn't like that. Our loyal customers. And when we started having good results with our loyal customers, our hospital systems, our other mobile health providers in our community came to us with a problem they had and asked us to help be the mortar or the caulk or whatever the heck you want to call it to fill their void. So here's a couple of them. So we had a cardiologist who came to us with an issue about CHF and readmission. They had these patients that kept coming back. And their point was, most cardiologists really don't have clinics anymore. If they do, it's maybe once a week. So they took care of this person in the hospital, they discharged him. 3 or 4 days later, the patient's decompensating. They call the cardiologist office. Well, they call the primary care office, who says call the cardiologist. The cardiologist doesn't have an office. So where do they send the patient? Send him to the ER. So when they go to the ER doc says, right, this guy is sick. Yes, he is. He was sick when he went out of the hospital. But what do we do in the ER? We put him back in the hospital because it's easier for us than to send them out to diuresis and do whatever. So they came to us with a problem they had. So the resources we utilize with them as a cardiologist, primary care physicians, the case managers, so these discharge planners who identify people that have a history of readmission or at high risk for readmission, then enroll patients to us. They literally fill out an online form, comes to us with discharge. The patient is consented for the program, obviously, but then all the information is shared, and we literally get a whole printout of the summary, discharge summary, the plan of care, everything for them. And then within 24 hours of them being out, we're in the home. And we're going over everything with them. We spend a lot of time simply on health education. In fact, we have a Euroqual, it's out of Europe, a health analysis that we ask patients, what is your perception of your ability to manage this disease process? They just got diagnosed, or they have this disease, they don't know what it is. They were told their heart doesn't work right. And so on a scale of 1 to 100, where is their ability to manage their health? Where do you think it is? It's down here. And I just got 3, I was just reading them right here. They're all, high one is 40, and this guy's had 3 prior readmissions. So he's had CHF for years, but he has a 40, his number, his perception of his ability to manage his CHF is a 40, all right? Now, when we go through this, we talk about disease monitoring. We go and open the refrigerators, which most cardiologists don't do. They don't go to the home and open the refrigerator. In our population, when you have somebody with CHF and all you see is pepperoni pizza and pickled pig's feet, you have a high incidence of readmission. All right? What's that? Well, that thing's going to kill you. So we actually have a diuresis protocol. We do have an intervention ability because our first year we didn't have the intervention ability. We identified people decompensating early. Their weight was going up, they couldn't wear their shoes, they couldn't put their rings on, but we had nothing to do. We called the primary care physician or the cardiologist who told us to do what with the patients? Send them to the ER. Guess what happened? Readmissions went up. So when we instituted our diuresis protocol, we were able to finally prevent the readmissions. Because when we see the weight going up based upon their weight gain, we do little eye stats, we look at the creatinine, we look at the potassium, and we adjust their diuretics right there in the house, and we follow them on a daily basis. And amazingly, when 3 days they gain 2 pounds, and you come back the next day after doubling their diuretics for 24 hours, they're back down to their dry weight. They're back down to their baseline weight. And so it was finally the thing that helped us tip the scale. We measured patient experience. We measured the clinical outcomes. Obviously, the integration, because we found our for-profit hospital had no problem referring all the unfunded patients to us to get them set up with the county system, which they couldn't the system. So, and we had great doctors that loved this program, but when we called them, they never answered the phone. And so we had to really push the integration piece. We'll do this for you, but you work with us. Obviously, the provider experience, the cost effectiveness, I mean, based upon, once again, CMS's numbers, what they're paying, it's substantial, but once again, this is probably a rounding error to somebody much larger than I am. But the patient experience is phenomenal. These people get it. I mean, they don't want to go to the hospital. When they call their doctor and the doctor tells them to go to the hospital, they're like, not again, because they know they're going to go to the ER, and guess what? They're going to end up back in the hospital. They're going to give them a bunch of stuff. They're supposed to be there for 24 hours, but they run back and forth to the bathroom constantly because they're peeing off. They're tired. They go home, and guess what? It's a cyclical thing for them. It keeps happening over and over and over. The other thing we had our hospice companies come to us and say, we have a problem. So the way hospice is set up, it's global. When somebody's enrolled to hospice, they sign over all the benefits of the hospice agency. Therefore, the hospice agency is responsible for all of the health care. If that individual goes to the hospital or to the ER, hospice becomes the payer. So they said, we have people that we know, the families are high risk, and when the time comes, they are going to freak out. And no matter what we do, they're going to call 911 because we control that final safety net point. And so they partnered with us. We went out, when they identified these patients, we went out and met with the families. We explained the procedure. We explained what we were there to do. We told them that we were nothing but an alternative to your hospice organization. So if you call and the nurse is busy or you can't get the nurse to answer the phone and you're scared, here's another non-emergency number to call. We will have somebody come out. We will evaluate them. We will get in contact with the hospice. We will do nothing but deflect it right back to the hospice agency. They have these care packages, little pain medications, anxiolytic medications and stuff that the patient's family has. The family doesn't want to administer this stuff, so we help administer their care package. And if all else fails and they call 911, we still send a traditional response. We have that address flagged in the CAD, so first responders, ambulance, everybody else knows it's going there, that there is a hospice patient at that location. But on the other side, the phone's being picked up calling the hospice agency. Say, you know what, we just got a 911 call from here, you better get your ass over there. Right? Because if the family wants to revoke hospice, we will still do that. We honor their wishes, but this allows the hospice agency to get over there and go through the processes. The families are scared. I mean, that's really what this is about. And it's been successful. We have taken over half the people. I should say successfully. They passed to the other side as expected. But we've had one revocation, and that family revoked 3 other hospice organizations, so it probably wasn't a surprise. But the feedback from I shouldn't say patient experience, the family experience has been phenomenal. Because we sit there, we're not on a time schedule. That's the success of hospice. They sit there, they explain things to the families, they talk them through the process, they explain why those funny noises are happening, what's going on with the patient, and that's all they want is that comfort net. So, as we talked about this, we really came up with this piece. Because there's state officials here, the regulatory bodies are very concerned about this title of community paramedicine. Some states are very supportive of it. We're in one right now. Some are not, and they're putting up roadblocks. We've got folks here from the National Registry, the testing. I mean, this is a much bigger piece than simply community paramedicine. And since every state, what paramedics or EMS professionals can do varies, it's on a larger scale. I think in many ways we have really narrowed ourselves in EMS, thinking that we can do everything with just EMS professionals. You know, maybe for years now we should have been integrating with other health professionals, from physicians, the advanced practice nurses, PAs. Take your initial of sorts. Ian's smiling over there. I know it about it. But the existing providers in scope, sustainable funding is a big thing. All right, we don't want grants. Grants are wonderful, but grants aren't sustainable. Okay. We were quite upset initially that we didn't get a CMS Innovations grant, but now we say thank you, Jesus, every day that we regulatory, the papers, everything that has to be done is so over-consuming. And we all in this room should be worried about the people who got the CMS Innovation Grant, because if they are not successful, we are probably screwed. All right, so reach out a hand to those folks. There's no question that what we do, we are versatile, we're adaptable, we are customizable. There's no question about that. This is a politically sensitive thing. I mean, we've had some great conversations with some of you. The group of us got together truly. We were all friends. This started in a bar, and we thought when we got together, we don't know if we'll accomplish anything, but at least we'll drink a lot of wine, okay? And we did. But we really realize that this is much bigger than us. And we have to take our small group, our small circle, and make this circle bigger before we go out to the much larger circles. The other potential threats, as we talked about yesterday, people, it's okay if you're in the tent peeing out, but we don't want people outside the tent peeing in, okay? There's no question about that. Scalable, reproducible is a big thing. Because what you guys have done here in Minnesota is not reproducible in Texas, all right? If you expect the state legislatures to support anything in Texas, good luck with that. That's why we have delegated practice, and we don't like rules, we don't like government. Has to be patient-centered. Everyone in this room is patient-centered. Everybody has anecdotal stories about all the wonderful things that we have done and the things that we've prevented, right? And we don't have a unified voice talking about that. EMS leadership is really the role here. I mean, we have to, our model of public safety EMS is non-sustainable, all right? If you think that the healthcare payers are going to continue to pay a glorified taxi with limited evidence that we make any difference at all in what we traditionally do, you're out of line. All right? There will be people that say, hold my beard and watch this. Well, at least that's what they do in Texas. I don't know what they do in your part of the country. And in Wisconsin, they do that too. Yeah. We have to be there for those moments. So what are we going to do to sustain our systems in the meantime? Because if you have a UHU of anywhere from 25 to 75, there's still time and there's still things that some of us can do in the meantime to offset that cost of readiness to be there when Brent has his event. We have to support traditional EMS, but we have to also support the evolution of EMS. That's what I just said. So the key concepts are this. This is the talking points today. EMS has the opportunity to drive a new practice of medicine. Why do we call it mobile integrated health practice? Because if you want to go to CMS, you want to go to a payer and start to ask them to bleed from another wound, it's probably not going to happen. So are there existing codes as a practice of medicine, as a physician, that we can fit into? And without creating something new, is there something that this new practice of medicine can actually already fit into? EMS will not own this space, all right? There are lots of trains that are out of the stations and they are headed down the road. Fortunately for us, their tracks are not too much ahead of the train, all right? And so when the trains fall off the tracks, they end up calling us. So the question is, can we work with those trains? Can we be the tracks? We talked about this yesterday, We have the patient in the hub of the wheel, and there are tons of spokes hanging off that hub, and as the wheel spins, the spokes are flying all over the place. We believe that EMS, we are the rim. We are the rim of the wheel that can take all of those spokes and put them in line and crisscross them beautifully and make the wheel roll down the road with the patient in the center of the wheel. We can integrate the skill sets of our clinical colleagues and what we're already doing today with the experts on mobile health, which is us. We have the infrastructure. We have the call centers. It's what we do every day. So instead of a hospital system recreating this wheel, trying to come up with a call center, a dispatch center, and all this mobile, availability of provisions, why not just take their provider and put them on the ambulance or put them on our device that already exists using our infrastructure? Community paramedics, like emergency paramedics, are an integral part of the healthcare system. There's no question about that. So in case of emergency, please go to the nurse emergency room. This is the truth. I was, Eric and Joan and those, they worked on that huge scale. We see it every day. We see the broken system. We see the patient's frustrations. We go to the house and know what the patient needs just to get into their primary care physician's office. But it's very frustrating when you ask the patient, well, did you call your doctor's office to try to get in? And they said, well, yeah, they're the ones that told me to call 911. All right? The system is broken. And we have a narrow opportunity to make it work. And I'm concerned that I know that Dr. Wilcox and Gary and a lot of you in here have worked decades on this community paramedic concept. And finally it is taking off. The problem is it's going 90 miles an hour and it's being pulled in 15 different directions. Right? And I'm not sure that the time it's going to need to come on a state regulatory scale of national recognition is going to fit in the time window we have with the train pulling out of the station. So I believe, me, not MedStar, none of us that are sitting here are representing our organizations. We are representing ourselves and our belief in what we do. Because most any of, especially the physicians in here, if we would just go work 12 shifts a month, quit all this 21 minutes, as my wife says, our lives would be a whole lot better. But we're all psychotic. We all have this delusion that we can make things better. It may be, I don't know.